Hello, everyone. Thank you for joining us. Thank you for joining us at this webinar hosted by MITEC Medical. MITEC Medical is the regional distributor for Apollo Endosurgery and Boston Scientific, among other well-established medical device brands. I am Kessa Pulchan, the sales representative for the Southern Caribbean. And tonight, we're very pleased to have Dr. Amrit Rambhajan presenting for us today on Take That Weight Off Your Shoulders. Dr. Rambhajan studied at the College of Royal Surgeons in Ireland and completed his postgraduate education in general surgery at UMDNJ University in New Jersey. He then went on to complete a fellowship in minimally invasive and bariatric surgery. He's board certified in general surgery by the American Board of Surgery, board certified in bariatric surgery by the American Society of Metabolic and Bariatric Surgery, and the Fellowship Council. His clinical expertise includes a wide range of procedures, including sleeve gastrectomy, gastric bypass, the intragastric balloon, gallbladder and biliary tract procedures, procedures for gastroesophageal reflux disease, achalasia, hiatal and paraesophageal hernia, gastrointestinal malignancies such as gastric cancer, colorectal cancer, small bowel tumors, as well as breast cancer procedures. In addition, he also does acute surgery of the GI tract, including appendicitis, diverticulitis, and peptic ulcer disease. Throughout the presentation, we would love for you to participate, so feel free to enter any questions that you would have in the chat, and Doctor will address them at the end of the presentation. So, Dr. Rambhajan, I now pass everyone on to you for you to explain how they can take that weight off their shoulders.
All right, thank you. Good evening, everyone. Thanks, Kessa, for that introduction. Pleased to see that we have quite a few participants here now, and hoping that we get a couple more people logging on shortly, but we will go ahead and get started. So obesity is a big problem, and it is constantly being underdiagnosed, and as such is being undertreated, not only in Trinidad and Tobago, but across the world. Patients are only receiving advice about obesity only when the complications of the disease have already started occurring, and we are spending a lot of time and effort in treating the complications of the disease as opposed to treating the disease of obesity itself. So, obesity is the excessive or abnormal accumulation of fat throughout the body. This fat could accumulate under the skin where it is more visible, as well as around our visceral organs, namely the liver and other organs within the body. That central obesity or deposition of fat around in the abdomen actually carries a higher risk of cardiovascular disease than does other weight distributions of fat. So obesity is not only of cosmetic concern, as obesity increases our risk of many diseases, cardiovascular, diabetes, hypertension, etc. And we'll come to that in a little bit more detail later on in the procedure. Of note, the Caribbean is one of the most heavily affected regions in the world. We have a very obese population in general, and Trinidad specifically, about 29% of adult women in Trinidad are considered to be obese, and about 12% of adult men in Trinidad are considered to be obese. That gives us roughly about 20%, or 1 in 5 of our adult population is considered to be obese. And that trend is very similar throughout the rest of the Caribbean, Bahamas, Antigua and Barbuda being especially badly affected by obesity. But it's not only the adults within the Caribbean and the West Indies that are being affected by obesity, but our children. With each passing generation, our children and adolescents, the prevalence of obesity is increasing. And the prevalence of obesity in children in the Caribbean is about 2 to 3 times higher than it is in the rest of the world. When we look at the United States, it is projected that by about the year 2030, which is not too far away, that's only in 7 years from now, 1 in 2 adults in the US will be considered to be obese by the year 2030, and 1 in 4 adults will be considered to be severely obese. And we'll talk about what the difference between obese versus severely obese is and go through some of these definitions so that we can better understand the terminology of this disease so that we could start talking about what we can do to start tackling this problem. So the easiest way for us to measure and define obesity is by using your body mass index, which is a very simple ratio that is done in the office. You can do it at home as well. And it's a ratio of your weight in kilograms over your height in meters squared. And it's very simple. You could weigh yourself, get your height off the back of your ID card, and you can plug that into any BMI calculator that you could find online. Type in BMI calculator on Google, and the first 1 or 2 ones that come up, just use that. So a normal BMI is considered to be a BMI of 19 to 25, and that's considered to be a normal weight. As we start to get higher in BMI 25 to 30, we call that being overweight, and BMIs over 30 puts you in the category of being obese. Morbid or severe obesity, also known as class 3 obesity, would be persons with a BMI greater than 40. And the risk to our overall health increases as our BMI increases as well. So, some of the dangers of obesity. Number one, the number one danger that I put at the very top of the list is the increased risk of death from all causes. So our longevity or lifespan is severely decreased by being obese. For patients who are in class 1 obesity, that is a BMI of 30 to 35, those patients' lives will be shortened by about 3.5 years. And once you get up to the class 2 level, 35 to 40 BMI, your lifespan is shortened by about 10 years. And patients above 40, their lifespan is going to be shortened by about 13 years. So that is really very, very significant, especially when we are talking about the next generation, the kids, the adolescents right now having a high prevalence of obesity within their age group. There was a large study that was performed by Cambridge University as well as Harvard Medical School, the public health departments of those universities, and this was published in 2016 in the Lancet, which is a well-known medical journal. And it was found that the BMI category with the lowest mortality was actually patients in the class of 22.5 to 25 BMI. And as the BMI increases, the risk of death increased. So 25 to 27.5, the risk of mortality increased by 7%. In the 30 to 35 BMI, the risk increased by 45%. And in the 35 to 40 BMI, the risk was increased by almost 100%. Some of the other things, apart from increased risk of death from all causes, some specific causes that makes us less healthy as we become more obese include hypertension, type 2 diabetes, hyperlipidemia, stroke, coronary artery disease. And these 5 things that I called these diseases are plaguing Trinidad and Tobago. I don't know what percentage of bed spaces treatment of these diseases and its complications is taken up, but it is definitely more than 1/4 to 50% of bed spaces that are being taken up by treating these non-communicable disorders, or NCDs as we commonly hear it being referred to in the media. So again, high blood pressure, type 2 diabetes, hyperlipidemia or high cholesterol, strokes, cardiac problems, namely a heart attack, heart failure. Heart failure is when fluid starts pooling around the lungs, start pooling around in the abdomen, legs become swollen, it becomes difficult to breathe, it becomes difficult to do your activities of daily living. Cardiac arrhythmias like atrial fibrillation is more likely in patients who are overweight. Cancer, there are a couple cancers that have a strong correlation with being overweight, and I listed a couple of them that are very, very common in Trinidad: breast, colon, and endometrial cancers, namely. Other ones include kidney cancers and liver cancers are more common as you put on weight. Arthritis. This is a common one amongst my patients. They are complaining of pain in the knees, pain in the hips, difficulty with ambulation, unable to keep up with the kids. And it really is a problem that is a progressive one, meaning that as you get into your 50s, we are seeing these patients needing knee replacements, etc. Reduced fertility amongst the childbearing age females, with women in their 20s and 30s. A lower quality of life, less enjoyment from life, and depression, anxiety, and self-esteem. This is not a comprehensive list of all the things that are associated with obesity, but these are some of the top ones and the ones that we see very, very commonly or frequently. So, for many, the weight loss journey leaves them lost in the gap with few options available. We have diet and exercise at the very left-hand side here of this slide. And diet and exercise is really a cornerstone and a pillar of maintaining a healthy weight. However, diet and exercise alone, when we are trying to lose weight or get back to a healthy weight, is going to be unsuccessful for about 98% of patients within 1 year. Using those methods alone is very difficult to get back to a normal weight, or close to a normal weight at least, and maintain those losses for 12 months. Pharmaceutical, I put in the middle here, there have been a lot of pharmaceutical solutions or aids that date back maybe about 150, 200 years, and I'll talk about that briefly on the other slide. And there are a lot of breakthroughs, most recently in the last 10 years or so, we are having much better drugs on the market that are able to fight obesity. However, as of right now, there's a gap in the market in Trinidad where these medications are not readily available. Also, the total body weight loss that we are getting or those patients are able to get is in the vicinity of about 5 to 10% of total body weight loss with the medications that are currently available. But importantly, medications available now in US markets and other Western markets are definitely better drugs than what was available on the market about 10 years ago. And then we have a big gap here between diet and exercise essentially and surgery. And to understand what we're going to use to fill this gap or what we have available, I thought it was interesting to take a historical perspective on this, and we'll just go through some of the highlights in the history of obesity medicine, essentially. And it starts back in 400 years before Christ, where Hippocrates, the father of medicine himself, was recommending a diet of exercise and vomiting to lose weight. And we'll see how the medicine of obesity has gone from a very haphazard way of practicing to now in the 21st century, a way of practicing that is really very focused around the science of obesity and following outcomes really very closely versus what was done 2,000 years ago, even 100 years ago. In the 10th century, King Sancho of Leon, this was a Spanish king. He was unable to go into battle. He couldn't get onto his horse, and his grandmother sent him to see a surgeon. And that surgeon sewed his lips together, and he was fed by a straw. Apparently it worked. He was fed a concoction of herbs and opium, which we will not recommend today by any means. Apparently he was able to get back onto his horse and get back into battle. William the Conqueror, from about 1,000 years ago, went onto an all-alcohol diet, which we will also not recommend. And then we come into 1837. So we start getting a little closer to the modern era. And at least the modern recorded era, I should say. And in 1837, the first modern weight loss diet was invented or publicized, and this diet was based around vegetarianism. In 1862, the first weight loss book was published, and that was not published by a doctor or anybody in the medical field per se, but that was published by a man called William Banting, who was a coffin maker and a mortician. And maybe his idea to publish this book was probably he was seeing a lot of deaths of overweight persons dying early back in those days. 1893, Dr. Frank Kellogg. Frank Kellogg and his brother, I think his name was William. These are actually the Kellogg brothers who came out with Kellogg's cornflakes that we still have on the market up until today. Frank Kellogg came out with a weight loss pill that was based on thyroid extract. And he might have actually been the first bariatric surgeon having performed an alimentary weight loss operation back in those days, but it was not very well recorded. So he did not get the credit for that. 1898, Fletcherism. It's a doctor, I think he was a doctor named Fletcher, who advocated chewing his food 100 times before swallowing. He was called the Great Masticator. He was called the Great Masticator. Okay, sorry about that. He was called the Great Masticator. And even though chewing your food 100 times seems to be a bit ludicrous, this idea of chewing our food really very well, 30 times or less, is something that is oftentimes spoken about by dietitians as one of the tools in losing weight, as well as trying to keep weight off after any of these procedures are done. And essentially trying to extend the period that we eat for, and giving our body time to listen to the bodily cues that tell us that we are full versus we are still empty, as opposed to wolfing our food down and then we're not really sure when we are actually full, ending up overeating. 1918, the concept of calorie counting, and we still very much do this today and still advocate for doing that. 1925, this was an interesting one, and I have heard of people still doing the Lucky Strike diet. Lucky Strike as in Lucky Strike, the cigarette brand. And this is where Lucky Strike, the brand, was promoting cigarettes as an appetite suppressant back in 1925. Then we have the grapefruit diet. And in 1954, a surgeon called Kremen, I think he was from Germany, performed the first jejunal-ileal bypass. And this is the first recorded alimentary tract operation that was done for weight loss. So this is the first recorded bariatric surgery. In 1966, a surgeon called Mason performed the first gastric bypass. And back in those days, all surgery was done the traditional open format. So he performed the first gastric bypass, which was done for weight loss specifically. And this was modified from a previous known operation for peptic ulcer disease. Interestingly, that operation for peptic ulcer disease, we still perform that same operation till today. So 1966 to 2023 is 30, 40, 50, about 55 years now, the gastric bypass operation has been performed. It has now been modified, or a couple modifications have been done today. But essentially, the crux of the operation remains the same. 1976, Italian surgeon called Scopinaro is credited with performing and advocating for the biliopancreatic diversion, an operation whose concept is still practiced today. 1977, jaw wiring. 16 patients had their jaws wired to lose weight. We obviously don't do that anymore. And in 1980, the first laparoscopic appendix was done. And the advent of laparoscopy is what really pushed bariatric surgery and bariatric medicine and obesity medicine into modern day medicine, and really allowed it to pick up some steam, because now we are starting to be able to, the technology was there to offer procedures that are much less invasive, easier to recover from, etc. So the first lap appendix was done in 1980 at the University of Kiel. And interestingly, that was done by a gynecologist. And he wrote that both surgeons and gynecologists were angry with him and they virtually stoned him. I write that there because anytime something new is coming out, something groundbreaking, there is always a lot of maybe some anxiety and a lot of antagonism towards that new procedure until that procedure or technology is able to really prove itself and show itself. This intragastric balloon, which we are primarily going to be talking about today, has been around, or the concept has been around for a long time. The concept was first devised in 1985 with the first intragastric balloon. 1991, a company called Bariatric developed a balloon that would eventually become known as Obera, which is the balloon that we are talking about most commonly here. And the Obera was had widespread usage in Europe, Middle East, and Asia back in the 90s and 2000s. 1991, back to Trinidad, or coming to Trinidad now, Prof. Narayan Singh importantly performed the first laparoscopic cholecystectomy. So that's the first laparoscopic non-diagnostic operation that was performed in Trinidad and Tobago. 1992, the lap band, or the adjustable lap band, came out. And this is an operation. From time to time, patients will come asking for the lap band or inquiring about the lap band. And this is an operation that initially had enjoyed great favor among surgeons as well as the patients, because it was a relatively small operation. The morbidity or the complication rate was really very low. However, over the last 10 to 15 years or so, the lap band has largely fallen by the wayside because of poor long-term outcomes, and surgeons are spending more time over the last 10 years removing lap bands than putting lap bands in. So it has shown itself to not be such a great procedure, though we did have good outcomes in the early years of the lap band. So that is no longer a thing by and large. There's still a few surgeons in the US and I think Australia that will perform it. 1994, Dr. Alan Whitgrove, I believe he is still a practicing surgeon somewhere out in California, and he performed the first laparoscopic gastric bypass. So with laparoscopy being able to accomplish these big, difficult operations, these operations became more accessible. Patients were more likely to have the operation done because the recovery was much easier and the overall complication rate was much lower. In 2003, Magenstrass and Mill operation was devised, which is essentially the sleeve gastrectomy, recognizing that the sleeve gastrectomy on its own as a standalone procedure was an adequate operation and was a good operation for weight loss all on its own. Nowadays, in terms of bariatric surgery, the sleeve is the most commonly performed operation in the Western Hemisphere. 2008 was the advent of incretin drugs, and this is the new class of pharmaceutical agents that I alluded to a little bit earlier on today. A lot of them got FDA approval, a couple of them got FDA approval in the US around 2015, 2016. And in 2015, Obera received FDA approval for usage in the United States. Most recently, 2022, just last year, the endoscopic sleeve gastroplasty, Obera, or Apollo overstitch, I should say, received FDA approval to perform the endoscopic sleeve gastroplasty in the US. So US surgeons have been performing that now. It has been performed in other areas, as best as I could tell, for the last 3 to 5 years. So, as it relates to bariatric surgery, and the balloon is not typically considered to be bariatric surgery, but it's important that we review the guidelines of who is considered to be a candidate for bariatric surgery and how these guidelines have changed over the last 30 years. The first consensus guideline was published in 1991, and this was after a big conference held by the National Institute of Health, the NIH in the USA. And in a nutshell, the guidelines for bariatric surgery was bariatric surgery ought to be considered for patients with a BMI greater than 40 without related comorbidities. Comorbidities meaning the hypertension, sleep apnea, diabetes, hyperlipidemia, etc. or a BMI greater than 35 with obesity-associated comorbidities. Now, in the 21st century, and especially from about 2012 onwards, we started realizing that by having such stringent guidelines before offering surgery to our patients, that we were under-treating our patients and we were missing a good opportunity to treat, especially diabetics, when they were at a lower weight. So the American Society of Metabolic and Bariatric Surgeons and the International Federation for Surgery in Obesity and Metabolic Disorders, IFSO, met last year in December 2022, and they have amended the guidelines at this consensus meeting. And the guidelines are now: bariatric surgery ought to be recommended for patients with a BMI greater than 35, regardless of having associated comorbidities, or a BMI greater than 30 with associated comorbidities, or if other weight loss efforts have failed. So now we are able to reach patients at a much lower weight before the complications of the disease of obesity have started to set in. Also, the last note here says BMI greater than 27.5 for certain ethnic groups, namely persons of Asian descent, because we find that diabetes is very much more common at lower weights in persons of Asian descent, as well as the risk of cardiac complications is much higher in persons of Asian descent. So those are the guidelines, and now we will get back to how are we going to bridge the gap between diet and exercise and surgery. And that is where Obera, or the intragastric balloon, is going to come in. This is an effective weight loss option that fills the gap. Importantly, Obera does not require, or the intragastric balloon does not require, formal surgery. There are no incisions, there are no cuts, and with that, there is very minimal downtime or recovery period after the procedure. It's a non-surgical option that is meant to give patients the momentum they need to amplify their weight loss efforts and develop a more confident, healthier lifestyle. So, who's a candidate? In general, patients with a BMI of 27 to 40, the intragastric balloon acts well as a standalone procedure. Or the other range of patients that we are trying to reach out to are patients with BMIs greater than 55 or 60, who may have, or who may also have, some associated comorbidities, especially respiratory problems, and the balloon is to be used as a bridging procedure to another bariatric operation. In those patients in that BMI category, the balloon alone will not get those. We don't expect the balloon on its own to get those patients to where they need to be, but it is a great adjunct to formal surgery to get those patients to a weight category to allow to reduce the complication rates of those operations and allow us to do those operations more safely. So that's for patients with a BMI greater than 60. All right, placement of the Obera. So the Obera, or the intragastric balloon, is placed via what is typically a same-day procedure. You come in the morning, have your procedure done, and most patients leave the hospital 2 to 3 hours after the procedure is done. We are doing it using either conscious sedation or using sedation medication. We have done a couple of them, one patient, I think, so far under general anesthesia. The procedure is very quick. It takes 20 to 30 minutes. Patients go home the same day. The balloon is placed in the stomach. So when we put the balloon down, it is put down in a deflated format, and that is roughly, it is I don't want to use the word flexible, but a very pliable material. The outside of the balloon is made out of silicone, so it's nice and smooth, and it has a very even surface to it, and it's put down deflated through the mouth down into the tummy, and then we inflate it under direct supervision. It's not inflated with air. There are some other balloons on the market where air is used. We use saline to inflate the balloon, and by putting fluid into the balloon, we tend to get better results than the balloons that use air. Right, so we look at this animation here that tells the story really very well. So the balloon is introduced, or the scope with the balloon is introduced down the esophagus into the stomach. We keep looking at the balloon while we fill it up with saline. At the end of the procedure, we pull the tubing off, and the balloon then is meant to sit in the mid portion. The balloon is then meant to sit within the mid portion of the stomach. As you can see, whatever you eat or drink after the procedure settles on top of the balloon. Whatever you eat or drink after the procedure settles on top of the balloon and then slowly trickles beyond the balloon to empty out into the small intestine. Right. Let's take a look at that one more time. The mechanism of action. So how is this balloon meant to work? So obviously, the most glaring mechanism here is this balloon is going to take up space within our stomachs, thereby reducing the effective capacity of the stomach. These balloons are filled between 400 and 700 milliliters of fluid. And the amount of fluid that we put into the balloon has nothing to do with how much weight somebody might be hoping to lose. It really more has to do with the amount of space that balloon is taking up in the stomach, essentially the size of that person's stomach. The taller you are, the larger that stomach tends to be. But the average that we are using is roughly about 550 to 600 milliliters of fluid. So one, it works by the mechanical effect, reducing the gastric volume. Two, it also delays gastric emptying. So by your stomach taking longer to empty, you will have that feeling of fullness or feel satiated, as we say, for a longer period. This last point, number 3, has not quite 100% flushed itself out, but we believe that there may be some effect on GI hormones. Bariatric surgery definitely has an effect on GI hormones. And we think that the light amount of stretch that the balloon places on the walls of the fundus of the stomach or the body of the stomach as well may reduce secretion of a hormone called ghrelin. Ghrelin is a hormone that is primarily made in the stomach that controls or helps to control our appetite. Essentially, ghrelin makes us hungry. Removal of Obera. So the removal of the balloon is a very straightforward procedure. Prior to last year, Kessa, you might be able to correct me on this, but back in 2021, the Obera balloon that was on the market was a 6-month balloon, and as of 2022, the Obera 365 is now on the market. 365 indicating that we are allowed to, or we can put this new balloon and leave it in for a total of 12 months. We try very hard to not leave it in any greater than 12 months. Kessa, that's correct?
Yes, and it's also FDA approved. It's the only intragastric balloon that is approved by the FDA for the placement of 12 months.
Good. So we try to take them out, or I shouldn't say we try, we definitely take them out under 12 months. The reason for not leaving it in any longer is to try to avoid any problems with the balloon and the material that the balloon is made for. So we are taking them out within 9 to 12 months, most of them in and around the 11-month period, give or take. And we started this balloon placement in February of last year. So we are just upon taking out a couple balloons. The first 2-3 balloons have come out already. And again, it's a non-surgical procedure. We go back down with the endoscope, we puncture the balloon and remove it through the mouth. A very straightforward procedure. So in a Brazilian study, So in Brazil, they have a huge population that they have performed balloons on. I think the last I saw was probably about 20,000 in one study had been published, 20,000 balloons. So in a Brazilian study, over 85% of patients were satisfied and would recommend it to others. Important, very important when we talk about any procedure. And when I meet with my patients in the office, we spend a lot of time talking about what we hope to achieve by the particular procedure, weight loss, improvement of comorbidities, etc., as well as what the pre-op and the recovery period is like, as well as what the potential downsides, side effects, complications of the procedure. In general, there are very few major complications from the intragastric balloon. We do have a couple minor complications or minor problems or adverse effects that we see fairly frequently. And the number one adverse effect that we see very frequently, and I will tell you about this in the office when we meet as well, is that of nausea, vomiting, and discomfort. Almost everyone will have at least 1 or 2 episodes of vomiting after the balloon has been placed. And this slide here says that it typically resolves within 3 to 7 days. And I have found that for most of our patients, that nauseousness and vomiting resolves within the first 3 to 4 days after the procedure. Very rarely would it be prolonged to the 7-day mark. Minor complications also include acid reflux. We've had a couple of patients who developed some acid reflux symptoms throughout during the time that they had the balloon. And this has been very easily treated using acid reduction medications that are readily available in Trinidad and Tobago. Right, so let's look at the weight loss. The balloon beats diet and exercise for weight loss at both the 6-month and 24-month marks in this one study that followed patients for a 2-year period. Total body weight loss in this study showed 16.5% after 6 months, and this study would have been done using not with the Obera 365, but with the 6-month balloon. That's an important distinction here. Much of the data that is going to be presented here would have been with the 6-month balloon. This is a very important slide because this is really what sets the Obera procedure or the intragastric balloon aside from other weight loss measures that may be attempted. Namely, you're talking about plastic surgery nowadays. There's a lot about lose weight with plastic surgery and liposuction, etc. And this is the big difference here, that those types of procedures will make zero difference to your overall health. It will not change your hypertensive profile, diabetes, etc. And we are seeing big improvements, if not resolution, big improvements with high blood pressure, diabetes, respiratory disorders, such as sleep apnea or hypoventilation in obesity, as well as arthritis. Not as good for high cholesterol, but still seeing improvement in about 50% of patients who have the balloon. So we are seeing some really good effects here from the balloon as it relates to comorbidities. 89% of comorbidities are resolved or improved. Couple other studies here looking at the Brazil multi-center study, Spain single center study, 300 patients, 700 patients, and EWL means excess weight loss. And they had 48% plus or minus 28. This one 41% plus or minus 21. What we have been finding with the patients that we've done so far is that the majority of weight loss tends to occur within the first 6 to 7 months after the procedure is done. And we are getting roughly to about the 13, 14, 15% total body weight loss. Right, so that's a little bit, total body weight loss is a bit different to comparing excess weight loss, but 15% total body weight loss. Most patients are coming in and starting the procedure at about 200, 210 pounds with a BMI of roughly 35 has been the average BMI. And those patients are losing 25 to 30 pounds. Actually, the first patient, the first Obera patient did extraordinarily well, and she lost 50 pounds in the almost 12 months that she had her balloon in for. So we have globally proven real-world results. Interestingly, there are a lot of balloons on the market. There are fewer balloons that have FDA approval, and of all the balloons with FDA approval, the Obera balloon is the one that has been most rigorously looked at, studied, and published about. We have over 200,000 cases done, and more than 20 years this balloon has been used for weight loss, 20 to 40 pounds, and I think that is about right. Designed to be the ideal balloon, effective. Two important points here: non-ulcerogenic. There have been some other generations of balloons that were made of I'm not sure exactly what the material was, but it was a much harsher material than the silicone balloon of the Obera, and there was a high incidence of ulcers and inflammation within the stomach. The balloon is fluid filled, as opposed to a couple other balloons that have approval for use in the UK and Europe, where those are filled with air. The fluid-filled balloons have been performing a bit better than the air-filled balloons. Again, we fill it a maximum of 700, but the average has been in and around 550 to 600 mLs. And there is a radio-opaque valve on the balloon, a little white dot on the balloon, so it can be identified via X-ray. Importantly, and the dietitian is really the best person to speak to you all, or to speak to you about this before and after the procedure and help coach you through. But I stole this slide from Dr. Thacker from California, who gave a nice talk on another procedure the other day. So I give him credit for these 5-point plan to eating after the procedure. 1, measure your portions. So measure the portions before you go to eat to avoid feeling full. Schedule your meals. Don't wait until you're very hungry to start looking for something to eat. That includes not only scheduling, but preparing meals beforehand and having a plan for eating. Tracking your intake using apps. There's several weight tracker apps that are available. Many of them are free. I'm trying to remember the name of the most popular one being used in Trinidad now, but it has virtually everything that we would have: callaloo, dal, everything that we have in our diet here. You'll find it on that app. So weight tracking and calorie tracking apps, importantly, are a good adjunct. Choose healthy items. A diet coach is very helpful for this reason. 1, to help identify what we should be eating, and 2, to not take the fun and enjoyment out of the food that we are eating. And manage stress and other triggers. Oftentimes, many patients will take a step back in terms of their diet with, daily stressors, family life, work life, etc., and may go back to previous eating patterns. Obesity is a chronic disease like diabetes, like hypertension. Diabetes and hypertension, for the most part, forget surgery and forget these other adjuncts here, for the most part will require lifelong treatment with medication. And same thing with obesity, it requires lifelong diligence. So, before I move on to the other options that we have available, I am trying to think if I might have forgotten anything as it relates to the balloon. We will get to some of these questions shortly. MyFitnessPal, Thomas, you remembered it very well. MyFitnessPal is the app that that has the callaloo and the dal and the dumpling and all of those things on it. So we'll talk real quick on the other options. Right, we'll talk real quick on the other options and then we will get to the question and answer. So, very exciting, the endoscopic sleeve gastroplasty. We have not yet started it in Trinidad, but within the next 12 months or so, we hope to start getting this procedure off the ground. This is a completely endoscopic procedure. So again, incisionless procedure, no cuts on the abdomen, non-surgical weight loss procedure, and it is using the endoscope and a special suturing device to fashion the stomach and make it look as if you have had a sleeve gastrectomy. The laparoscopic sleeve gastrectomy, again, the most commonly performed bariatric operation in the Western Hemisphere. The laparoscopic Roux-en-Y gastric bypass, or just the gastric bypass. This is, at consults, I typically would call this the Rolls-Royce bariatric operation, meaning that this is the operation against which we will compare every other procedure to see, is it as good as the bypass or is it even better than the bypass? The mini gastric bypass is a little alteration on the gastric bypass to make this operation a little bit quicker and a little bit smaller, supposedly with lower morbidities, complication rates. Single anastomosis, duodenal-ileal bypass, sleeve-ileal bypass, and the list goes on. There's a lot of innovation in the field of bariatric surgery. A lot of surgeons doing some very exciting things as we try to tackle this, this disease that is really, really plaguing us. So, question and answer. I hope I didn't take you all too long. It's been about 40 minutes, give or take. So, hope I can answer a couple of these questions. Right. Second question. I've been on a health journey along with my sister for over a year. She has lost more than 100 pounds while I've seen little to no progress. We have similar diets and exercise regimens. What could be the root cause of her having so much progress while mine is stagnant? This really underlies, this question really shows us or demonstrates a bit the multifactorial disease of obesity. It is not simply diet and exercise for the vast majority of patients. And your sister has done really very well with 100-pound weight loss. That is absolutely remarkable. Obesity also has some hormonal influence in it. It has a genetic component, even though your sister does not necessarily mean that the genetics are the same. And, it sounds as if you are someone who probably should or may benefit from some sort of other treatment plan. Is there any risk of the balloon bursting or deflating in the stomach? This is from Tessa, not Kessa. This is from Tessa. Very good question, Tessa. We did not touch on that, but that is a fantastic question. This is the complication that I was most fearful of when we started doing the balloon procedure. It has been reported, but is very extremely infrequent. I think it's about 0.4, 0.5% of the time. Now, if that balloon were to deflate, what will end up happening is, one, you ought to, once you have the balloon in, you ought to feel the sensation all the time that you have the balloon. Every patient describes it slightly differently. Nobody describes it as discomfort, but there is the balloon is there. From the moment that you no longer feel that balloon the way that you were feeling it all the time, that may be a trigger that this balloon might be losing some of its fill, might have a small puncture, etc. And that is your trigger to come into the office. And what we will do is a quick x-ray to look at the position of that balloon And hopefully we get that balloon out before it has completely deflated. So in those patients, we have to remove the balloon before it's time. The balloon is filled with saline. So if the balloon were to deflate and that saline, the same stuff that you get in a bag of drips, if that saline were to get inside the GI tract, in and of itself will not be harmful to you. But we have to remove that balloon as soon as we can. Right, must it be removed if someone becomes pregnant? So this balloon is not advised, is not advisable during pregnancy or breastfeeding. So if a patient were to become pregnant while they have the balloon in, I will definitely recommend that the balloon is removed. All right, for those balloons that were removed this year, the average amount of weight lost, 30 pounds, 50 plus pounds, 30 pounds. And those are the 3 balloons that we have removed so far. So far we have been seeing very promising results. Right. After the year has elapsed, would another be recommended if the weight loss goal has not been met? That's an interesting question. A very interesting question. Now, I think importantly, our patient selection for the balloon is what is hopefully going to keep us, help maintain our good results over time. You're absolutely right. Some patients will not meet their weight loss goal. And the balloon, importantly, does not burn bridges. After the balloon is removed, there are a host of other procedures, medications, etc. Hopefully medications come on stream in Trinidad a little bit more. That will be available to the patient, namely formal surgery. Well, let's start with another balloon is definitely possible for that patient. Formal surgery, sleeve laparoscopic sleeve, or maybe the laparoscopic, or the endoscopic sleeve gastroplasty in time to come. Right, my BMI is around 48 and I have no known comorbidities. Would the intragastric balloon be an appropriate option for me? By and large, based on your BMI of 48, you don't have a definite contraindication to the balloon. Oh, that's one thing we didn't talk about. Who should not have a balloon? Who absolutely should not have a balloon? And the absolute contraindication would be patients who have had previous surgery on the stomach itself. So if you've had any kind of previous type of bariatric operation, the balloon is out of the question. If more commonly, if you might have had surgery for reflux, or if you've had a previous perforated ulcer and had to have surgery for that, the balloon is out of the question for those patients. Right. So yeah, by and large, having a BMI of 48 doesn't preclude you from having the balloon, but at that BMI, I typically would recommend an alternative procedure to the balloon. How often do complications arise? How often do complications arise? Very infrequently. Most common complication would be nausea, vomiting, and discomfort within the first 7 days, maybe 10 days for a couple of patients. The vast majority, first 3 or 4 days. When in the stomach, food remains in the stomach. Yes, so food is going to, I don't know if you could see this well, food is going to settle above the balloon. There's a delayed emptying of the stomach. It's going to take very long for that stomach to exit. For that food to exit the stomach. It may take 4 hours. It may take 12 hours for that food to exit the stomach. So your tummy will feel full for a longer period. You will feel satiated for a longer period. Can it be punctured in any way? I imagine it probably could be punctured if you were to swallow a fish bone or something. And I usually would recommend to patients to avoid bony fish and things with gristle, etc. But outside of that, I think it's very unlikely. when going about daily activities, do I feel this in my stomach? There is an awareness of the balloon. There ought to be an awareness of the balloon. And that awareness is what is going to tell us that the balloon is okay. Right, can patients who have had previous bariatric surgery have the intragastric balloon? The answer to that is no. However, the endoscopic overstitch device that we are going to start using in Trinidad, hopefully in the next couple of months, hopefully sooner than that, Kessa, will be able to help with some of these patients who might have regained some weight or want to get back on track after having had a previous bariatric operation, whether it was a previous gastric bypass or previously. Remove if pregnant, yes. Average weight loss. For costing on the procedure, I recommend or encourage you to call the office. I will put up my contact details afterwards. Do you only offer these services in Trinidad? So I spend a lot of my time doing bariatric surgery, but otherwise I do alimentary tract surgery, hernia surgery, etc. How soon after the placement of the balloon can I go back to work? Good question. It depends. It depends on the type of work that you are doing. If you have the option to work from home, then you could go back to work the day after the procedure is completed. If you have a very rigorous job, manual labor job, or job where you're on the road and you're back and forth, I would usually recommend that you take a couple of days off, 3 or 4 days off, and you're back out to work thereafter. And I think that is it for questions. Thomas, did I miss anything?
Well, Doctor, I'm seeing 1 or 2 more questions. One from Anna Shara. Actually, one from a person that's asking, do you offer these services in Trinidad? And another from someone asking, I need to lose 90 pounds, which would put me around my ideal weight. Can Obera work for me?
Yeah, 90 pounds is going to be a bit, to be very frank, 90 pounds is probably going to be outside of the range that we will expect. It's very important whenever I do any of these weight loss, bariatric metabolic procedures, it's important that the expectation is in line with what we could actually deliver, what we realistically expect the balloon to deliver. And I think 90 pounds is a bit outside of the range that we would expect the Obera balloon to deliver. I think the ideal patient for Obera are patients with a BMI of 27 to 40 will see an adequate weight loss that they will be content, happy with, and also have improvement in their comorbidities. Outside the range of a BMI of 40, we really ought to be looking at something else.
Okay, another question is, would the patient be awake before the procedure?
Yeah, so we are doing this procedure under conscious sedation or general anesthesia. Depends on the patient, depends on the BMI of the patient, depends on some other factors. The real name of the game is safety. Whatever is going to be safest for that particular patient is what we will recommend. And we look at a couple of different factors along with the anesthetist. So I do this procedure under with the anesthetist supervising the sedation that we are given. So it's really his choice as to what is going to be the safest way forward.
Okay, well, I know we're supposed to finish at 8 and we're running 4 minutes over time. So I'll just take one more question. If you had a hysterectomy, can you have the balloon?
Yes, most definitely. Patients who've had a hysterectomy, there's no contraindication to having the balloon thereafter. Kessa, you recognize this picture here?
Yes, I do.
So this is the picture we took after the first set of balloons that we did at Sinclair Medical. These procedures were done last February, so a year ago. We have the whole team here. We have two of our nurses, Melba and Summer, the endoscopy nurses. We have Kessa, who was here for the procedure, Dr. Benjamin, the anesthetist. We have Ricardo, who is the regional manager for distribution manager for MITEC Medical for the Latin America region. And then you had me there. I have office in Sinclair and Medical Associates, and this is the number you can use to get us at either of those two locations. So, one other thing, if anybody else has any particular questions that might come up after, you could feel free to email me as well. I did not put that contact detail here, but it is office@ttsurgery.com. Again, actually, Thomas, let me write it here. office@ttsurgery.com. All right. So thank you very much. Thank you for joining me, everyone. We had about 40-something participants at the maximum. I think it went very well. Sorry for those of you who missed out on the news, but I guess Disha Rambhajan she missed 40 extra viewers today. Thank you, everybody. Have a good night, and hopefully I see some of you all in the office soon. Take care.
Thank you, Doctor. Bye-bye, everyone.
Thank you, Doctor.
All right, Carmen. Take care. Bye.